Assalamu alaikum. My name is Irsal and the topic of my presentation is adverse effects of antipsychotics. My roll number is 63. Let's start. Okay, following are the adverse effects, that is EPS, anticholinergic side effects, cardiac effects, hyperprolactinemia, metabolic effects, and sedation. Let's discuss extrapyramidal side effects and TARDIVE syndromes, that is EPS and TD. What is EPS? EPS is a broad term that describes several types of acute and chronic drug-induced movement disorders. Acute dystonia, Parkinsonism, akathisia all occur early in treatment, whereas TD and tardive akathisia have a late onset, usually after years of treatment. Acute dystonia. Acute dystonia has the earliest onset of all EPS symptoms. Most cases occur within the first few hours or days after initiation of dose increases of antipsychotic medication. Dystonia is characterized by sustained muscle contractions. Common presentations of antipsychotic-induced dystonia include a sudden onset of brief or sustained abnormal postures, including trunk protrusion, oculogyric crisis, trismus, torticollis, opisthotonus, and unusual positions in the trunk, limbs, and toes. Rillinger dystonias are the most serious dystonias and are potentially fatal. Risk factors for acute dystonia include younger age, male gender, high dosage of high-potency typical antipsychotics, and previous history of dystonia. Okay, now let's discuss Parkinsonism. The clinical presentation of antipsychotic-induced Parkinsonism include bradykinesia or akinesia, which may be associated with decreased arm swinging, mask-like face, drooling, decreased eye blinking, and soft monotonous speech. Tremors, which is most commonly a rhythmic resting tremor and rigidity of the extremities, neck, or trunk. Now let's come to akathisia. Akathisia is a syndrome consisting of subjective feelings of restlessness or the urge to move and an objective motor component expressed as a semi-purposeful movement, most often involving the lower extremities, and an inability to sit or stand in one place for extended periods of time. Akathisia is observed in up to 50% of the patients treated with typical antipsychotics and ranges from 5 to 15% of patients treated with atypical agents. Akathisia is often extremely distressing to patients, is a common cause of medication non-adherence, and if followed to persist, can produce dysphoria and possibly aggressive or suicidal behavior. It is often difficult to distinguish from psychomotor agitation and worsening psychosis. Hence, the clinician must take care not to misdiagnose akathisia because an increase in antipsychotic dose could worsen this adverse effect. It usually develops within days to weeks after initiation psychotherapy. The pathophysiology of akathisia is unclear, but much attention has focused on two theories. Okay, the first theory states that the mesocortical postsynaptic dopamine blockade leads to increased locomotor activity. And the alternative theory claims that akathisia is caused by dopamine antagonist-induced dysregulation of non-adrenergic tracts that project from the locus coeruleus to the limbic system. Let's move to tardive dyskinesia, that is TD. TD is a syndrome characterized by involuntary chorioarthroid movements that occur in individuals taking long-term psychosis. The face, tongue, protrusion, lips, and limbs are commonly involved. The movements may be choreiform or rhythmic or acute in nature. TD occurs in approximately 20% of the patients who receive long-term treatment with typical agents. The cumulative annual incidence is approximately 5% through the first 4 years of treatment in an adult who receives typical antipsychotic treatment. Advancing age is the most consistently observed risk factor for the development of TD. The annual incidence rate of developing TD are 3 to 5-fold finger in older patients compared with younger patients. Now let's come to the anticholinergic effects. The anticholinergic effects are more significant with low potency typical antipsychotics with the atypical agents clozapine and olanzapine. Clinically, patients complain of constipation, urinary retention, and dry eyes, mouth, and throat. Dry mouth and throat can cause several additional problems, which are dental caries and weight gain if thirst is satisfied with high sugar drinks. Oral fungal infections can also occur if gum or liquids with high sugar content are regularly consumed. Anticholinergic properties are delirium and adynamic ileus. Interestingly, clozapine causes significant hypersalivation despite its cholinergic effect. The mechanism is unknown, but it may be caused by clozapine's augmentation of the adrenergic receptors and controlled salivation. Drug therapy with benzotropine, amitriptyline, and clonidine may elevate hypersalivation. However, these agents are not effective in all patients, and when they are beneficial, tolerance may develop. Although anticholinergic effects are a minor problem with high-potency typical agents, some patients may still have problems when anticholinergic anti-Parkinsonism agents are added to treat EPS. Now, we are heading towards cardiovascular effects. Cardiovascular effects are orthostatic hypotension, tachycardia, electrocardiographic changes. First of all, we are going to discuss orthostatic hypotension. Antipsychotic drugs can cause a variety of cardiovascular complications, but most common problem is orthostasis from alpha-1 adrenergic blockage. Low-potency typical agents and atypical antipsychotic pose the greatest risk for producing orthostatic hypotension. Orthostasis is most likely to occur during the first few days of treatment when increasing the dose of medication. Although tolerance usually occurs within 2 to 3 weeks, orthostasis necessitates slow dose titration early in treatment for patients who are particularly prone to this side effect. Tachycardia. Tachycardias may occur as a result of the anticholinergic effects of antipsychotic medications on vagal inhibition or secondary to orthostatic hypotension. Clozapine produces the most pronounced tachycardia. If tachycardia sustains or becomes symptomatic, low doses of beta blockers such as etinol or propanol can be useful once an ECG has ruled out other medical causes. Electrocardiographic changes. ECG changes such as prolongation of the QT and PR intervals, ST segment depression, and T wave flattening have been observed with antipsychotics. The most clinically important of these potential changes is prolongation of the QTC interval. All antipsychotics have the potential to prolong the QTC interval to various degrees. In 2000, Pfizer, in consultation with the FDA, completed a study in which the QTC intervals of patients taking several antipsychotics at usual therapeutic dosages and in the presence of a metabolic inhibitor was compared. Theoridazine was shown to prolong the QTC interval at least 20 minutes second longer than haloperidol, risperidone, olanzapine, or quetiapine. Now let's move to the metabolic effects. Hyperprolactinemia. Antipsychotic-induced hyperprolactinemia has come to the forefront because of differences found among the atypical agents. Before the introduction of the atypical agents, prolactin elevations was unavoidable because all atypical antipsychotic elevate serum prolactin by blocking the tonic inhibitory actions of dopamine in the tube infundibulator. Among the atypical agents, risperidone and, to a lesser extent, olanzapine produce a dose-related increase in prolactin levels that is equal to or greater than the seen with typical antipsychotics. The remaining atypical agents have a little impact on serum prolactin levels. Hyperprolactinemia is of clinical importance because it may lead to galactorrhea, gynecosmia, amenorrhea, anovulation, impaired spermatogenesis, decreased libido, and sexual arousal, and anorgasmia. Interestingly, the hyperprolactinemia is always associated with clinical symptoms. For example, Kainberg 8AL776 failed to find an association between sexual dysfunction and risperidone-associated hyperprolactinemia. Now, the second metabolic effect is weight gain. Weight gain is emerging as one of the most significant concerns associated with the use of antipsychotics, particularly among the atypical agents. The mechanism of antipsychotic induced weight gain is unclear, but antagonism of histamine H1 and serotonin 5-HT2C receptors have been implicated. A genetic predisposition exists for weight gain. A mutation in the 5-HT2C receptor gene may increase risk for weight gain from atypical antipsychotics. No genetic test exists to predict which patients will gain weight from the atypical antipsychosis. Another theory is that the potential decreased signaling of two serotonin receptors, that is 2A and 2C, increase calorie intake and appetite and or decrease metabolic rate. The higher binding affinity to the histaminergic receptor, the more that agent is likely to be associated with weight gain. Among the atypical agents, weight gain is most common with clozapine, olanzapine, lowest with ziprasidone and aripiprazole, and intermediate with risperidone and quetiapine. Now we are moving towards neuroleptic malignant syndrome. NMSI is a rare but potentially lethal adverse effect of antipsychotic therapy. The risk of NMS seems to be lower for atypical agents than for typical agents. However, cases of NMS have been linked to treatment with clozapine, risperidone, olanzapine, quetiapine, ziprasidone. NMS can occur hours to months after the initial drug exposure, and mortality rate is reported to be high as 20%. The incidence is estimated at between 0.02% and 3.23% of patients taking typical antipsychotic drugs. The cardinal features include muscular rigidity, hyperthermia, autonomic dysfunction, altered consciousness, extrapyramidal dysfunction, and akinesia usually develop initially or concomitantly with the temperature elevation as high as 41 degrees centigrade. Autonomic dysfunction includes tachycardia, labile BP, profuse diaphoresis, dyspnea, and urinary incontinence. Now we are going to discuss sedation. Sedation can occur with any antipsychotic agent. However, it is most pronounced with the low potency typical agents and with clozapine and quetiapine. Sedation at the beginning of treatment may be desirable for anxious or aggressive patients. However, persistent sedation during long-term treatment may adversely affect daily functioning and quality of life. Most patients develop some tolerance to these sedation effects over time, but it can be minimized by reducing the dose or shifting administration to bedtime. What is hepatic dysfunction? Let's discuss. Benign elevation in LFTs have been reported early in the course of therapy with most antipsychotic drugs. Such increases are rarely problematic, thus no routine assessment of liver function is mandated by FDA. A more specific hepatic complication, cholestatic jaundice, have been associated with certain antipsychotic agents. The phenothiazine, especially chlorpromazine, have been implicated. Most cases develop within the first month of therapy and usually are preceded by prodromal symptoms of fever, chills, nausea, upper gastric pain, malaise, and pruritus. Discontinuation of the phenothiazine and symptomatic care are the primary modes of treatment because the cholestatic jaundice generally is self-timing and usually resolve within 2 to 8 weeks. Occasionally, a more chronic course may develop. Once the sign and symptoms have been resolved, an alternative class of antipsychotic, preferably a non-phenothiazine, should be prescribed. Okay, now let's move to the ocular effects. The ocular effects of antipsychotic agents are well recognized and are generally of minor clinical consequence. Corneal and lens changes have been reported within the several phenothiazines and thiothiazine. Chlorpromazine is the most commonly implicated, with the risk being greatest with long-term high-dose exposure, 1 to 3 kg lifetime dose. If AS has not been had a slit lamp evaluation, an ophthalmologist should evaluate her as soon as possible. A 6-month follow-up examination is also indicated. Quetiapine should probably be discontinued if lens changes were noted on any of the examinations. Temperature dysregulation and dermatological effects. NM should be advised to wear a hat when working outside, drinking fluids, stay in the shade as much as possible, and seek a cooler environment if he feels hot. Antipsychotics can cause temperature dysregulation, likely by inhibiting hypothalamic temperature regulation. The net result is poikilothermia. The normal body temperature cannot respond to heat or cold, and patient become hypothermic or hyperthermic depending on the surrounding temperature. The strong anticholinergic effects of N-M-chlorambucil can impair cutaneous heat elimination and further exacerbate the problem. Olanzapine and clozapine have been strong anticholinergic properties, necessitating caution for patients exposed to excessive heat. Should also be advised to use a sunscreen with maximum sun protection factor along with protective clothing, because chlorpromazine induced photosensitivity can predispose him to severe sunburns. Seizures. Antipsychotic drugs can lower the seizure threshold, producing seizures in patients who previously were seizure free. Sexual dysfunction. Thyroxine is recognized as the most common cause of antipsychotic, including sexual dysfunction. Sexual side effects such as diminished libido, impaired arousal, and erectile and orgasm dysfunction, however, can also be reported with both typical agents and atypical agents. The causes of antipsychotic-induced sexual dysfunction are related to a number of factors, including hyperprolactinemia via dopamine blockade, alpha-adrenergic blockade, and anticholinergic and side effects. This was it. Thank you for your time and attention. Thank you.